Good morning, Ramesh. Good morning, Mansi.
Madhuji, good morning.
Good morning, Subhash Kaur. Good morning.
How are you?
Yeah, fine, doing fine.
You have preponed because to attend that Jayesh's webinar?
Yeah, exactly.
Yes, that I could get. So that we can also attend that.
Oh, of course. Last time you were there, no? I had a problem, talk. Today is going to be a really good program by Jalesh.
Yeah. No, but last time, there was no problem last time, no? What was the problem?
Last time there was not a problem.
What problem was there?
Last time I was doing the class on master class.
No, you did. No, you did bladder.
Bladder, yeah. This time, Jalesh. How are you doing, Subhash?
Good, sir. Good.
How is the situation there in Hyderabad?
The situation is extremely bad. Extremely bad. Extremely bad. Means everybody known to us, definitely from many people known to us, everybody, some relative has died, not ill, but died. How is it, Kerala?
Same here, almost same. Every day, I don't want to look at the paper now because every day.
No. Madhu, paper is different. Paper is somebody has died. But it is no longer like that. It is like my uncle has died. My uncle's cousin has died. My wife's brother-in-law has died. It is like that.
Oh.
So is it like that in Kerala also?
Same in Kerala. And
it is true that many people are recovering, but it's also true that many people are dying, which did not happen in first wave.
And many of them, it's unexpected death. They get admitted and next day they are no more. That's that's an unfortunate thing. Because they will think that he'll get over, but next day, highly unpredictable. People we think that will go away will come back. People we think will come out, they will go back or go away. Very unpredictable situation.
So Madhu, after that, that IAN webinar, no, I will give a call to you. I have to discuss some case with you briefly.
Absolutely.
It's on bladder only, but I want to discuss personally with you. So I will do that after that Jayesh things finishes. Then only it will take not more than 2-3 minutes.
No call.
But I don't want to in this forum, because that's I just want to have a personal.
Yeah.
So anyway, I think we already have almost 26 participants. We can start, Madhu.
Okay, we can start. Okay, shall we start now?
Yes, sir.
Yeah.
Manasi, can we start?
Manasi?
Dr. Madhusudanan, sir.
Yeah.
This is Dr. Subani.
Yeah.
From Lee. Can we have that link of Dr. Jayesh?
It's on the IAN. IAN mail, you check, it will be there.
Okay. Thank you.
They have sent on email to all the IAN members. So if you check your email, it will be there. I also got from. They call it some IAN digital team.
Okay. Yeah. Thank you, sir.
Madhu, sir, please. Welcome.
Yeah. So good morning to all of you. Just like last time, we are beginning the next session on challenging cases. So I'll start sharing my screen. Subhash, can you see my screen?
Yes, sir.
Okay. So as usual, we'll start with the first two short cases, then go for a long case. Okay. This is a 20-year-old female who presented with acute onset of dizziness and blurring of vision 1 day prior to admission. No other comorbidities, nothing else. She was no fever, presenting fever, nothing. This is the Ocular finding. That's why I wanted to show this video. Okay. The video, you're looking down, looking to the left side, looking to the right, looking up. No movement upward.
Try to go on looking up. നോക്കിക്കൊണ്ടിരിക്കും മോളെ. It's called stagnacy. I'll show you. മോളോട് നോക്കും മോളെ. It converges and not able to look up. Try to look up.
Okay. Anyone want to tell their comment? What do you see in the eye movements?
Convergent retraction nystagmus.
And one more thing.
And upgaze palsy.
Yeah, perfect. Upgaze palsy and convergent retraction nystagmus. So where do you think the site of lesion is? It is in the upper midbrain. Okay, the tactile area.
Okay.
Now, and how to prove it is upward gaze palsy? Suppose I say it is due to the defective weakness of aperture of the superior rectus bilaterally due to the nuclear third nerve. How to differentiate upward gaze palsy from an element paralysis? What bedside test will you do? Okay, let us see what I have did. It's a Bell's phenomenon. Asking the patient, yeah, eyelids open, ask you to close tightly. Eyeballs roll up. See, eyeballs rolls up. That means that it is an upward gaze palsy. To call a gaze palsy or human paralysis, you have to make the muscle move by some other reflex movement. So here you can utilize two reflex movement. One is Bell's phenomenon, the other is ocular reflex.
Madhu, can you please demonstrate to us these findings? What this
Again,
convergence
yeah.
retraction, how to look for it?
Yeah, sure.
Okay.
And initial part is okay. This part is the one. I'll come to that. Now you can see the eyes adduct and converge.
Try to go on looking up.
Now you can see very well. See the eyes simultaneously. Look at the nose, you can easily find out. Don't look at the eye. Keep it the bridge of the nose, you can find the both eyes adducting and looking up.
Yeah. That's very nice. Thank you. Yes, sir. Thank you.
Yeah. Okay.
Try to look.
And the other is the Bell's phenomenon, which is seen. Okay. Now, what other finding will you look for in this patient? Look for light near dissociation because that goes along with that site of lesion. So look for the pupillary involvement. Right, there's no light near dissociation. Pupil is reacting normally to light. That's only patient had got upward gaze palsy and convergence retraction nystagmus. So what could be the likely etiology in this patient?
Pineal gland tumor.
But demyelinating lesion could be. But if the patient had a small infarct, we will see this infarct here the diffusion weight. You can see it in the, a little more clearly in the, when the window is adjusted. We investigated thoroughly for any etiological possibility being a young person. Nothing could be found out. She improved totally in 2 days' time and follow up, nothing is happening. Subhash, what could be the reason for this kind of infarct? Any idea?
Is she hypertensive, diabetic? No.
Nothing. She's only 18-year-old girl. Sorry, 20.
And no other like migraine, collagen vascular disease, nothing.
Nothing. We investigated for all ANA profile, this also called thrombotic state, everything we did.
Very difficult, Madhu. We don't know. You see, technically speaking, if you go by the technical classification, then this is a lacune. But then, even that is a very uncomfortable because lacune in the absence of hypertension, diabetes, many times they are genetic, small vessel diseases. If you take, now this is a small vessel. If it is not a demyelination, then we have to think of a small vessel. But small vessel diseases, common causes are hypertension, diabetes, and lately genetic. But it would be very unusual to have just one vessel as a genetic and rest of the brain completely normal. So I would say we really don't know.
Okay. Thank you, Subhash. I think, shall I go to the next case now?
Yes.
It's a 9-month-old child, was perfectly all right 2 weeks back. And parents noticed this involuntary movement 4 to 5 times a day.
Madhu, before I forget, can you...
Please.
Just, I'm remembering as you asked me.
Yeah.
I have seen one patient exactly same, exactly upward. I'm talking about the last case.
Yeah.
In fact, I have a video which I will share with you. Exactly upward gaze palsy and exactly the same lacunar infarct.
Okay.
And he turned out to have a cardioembolic source. There was a left atrial myxoma. So I think you should, because we don't know what could be the cause in this, please get a TEE done to rule out any cardiac source. Sometimes cardiac sources can be very small, although they are big, but occasionally they can be very small.
Okay.
So I would definitely investigate her with all the procoagulant and of course cardiac with the TEE.
Okay, definitely.
Sorry for that. It came to my mind. Thank you, sir.
Thank you. This 9-month-old child was perfectly all right till 2 weeks back, and parents noticed this involuntary movements 4 to 5 times a day. Look at the involuntary movement. Other child is normal. I'll come just now. That's the moment. Okay. What do you think about the involuntary movement? Anyone?
It could be a focal seizure, sir.
Yeah, but is it a focal seizure? If you look like a little more once again.
But the eye movements are also this. I get it.
No, it is fully, it is affecting the facial, tongue, and limb. It's sustained movement, not a jerky movement.
But also involving the upper limb also, sir.
Yeah. It's a classical faciobrachial dystonic seizure. Why faciobrachial is kind of, you have seen it in the face and the naked. Dystonic means it's a little more sustained than a jerky myoclonic like movement as you see in a classical. Even though this cannot be called as a seizure, this is called as a seizure. So which condition have you seen this kind of a movement?
So LGI
Paraneoplastic.
Yeah, classically LGI1 encephalitis. But I have seen this involuntary movements in many normal individuals. You wouldn't believe I have seen in old people also I have seen with they recover spontaneously, some with carbamazepine, never recurred again. So I don't know what causes involuntary movement. This side also, so this child belongs to a doctor, so I investigated fully. So MRI brain was done, EEG was done, serum sodium was normal, and send the child's serum for anti-LGA1 antibody profile, autoimmune profile, and ask the child come for follow-up after 2 weeks because it will take 2 weeks for the result to come. So they came back after 2 weeks. By the time the result has come, the result is negative, but the movements have already totally subsided. I have not put the patient on any treatment. It subsided on its own. So this is the antibody profile for this side. So I think we'll see many things, we read many things in literature, but only time will prove that these are all related to VJKC or something else. Some of them are genuinely benign conditions. So this is some girl which exactly mimic. It subsided out altogether. Okay.
Madhu, many years ago, about I think 25 years ago or so, my own son started having some funny dyskinesias of the face. My own son. Okay. That was much before these antibodies and all that came, and so I was obviously worried, and I read Adams at that time. I'm telling 25 years ago, and it was written that there are many times children have benign dyskinetic movements which almost invariably go away.
Correct.
So I think there is a spectrum. They need follow-up. Many of them may go away.
Correct.
Particularly in the children.
Right. Exactly.
So follow-up is required.
Required. Absolutely.
But the benign variety is very well known and described long back.
Okay, these are 2 short cases now already mentioned. I've got the real case now. Now this is
so that could be still one of the autoimmune encephalitis, no, sir, because the newer antibodies are coming up. Like last time you showed one case where we had to send to the other center where they did a rare antibody.
Yeah, I agreed, but the one which is classically described, this kind of movement is described in LGA1. That's no other abnormality in this side. Other perfectly normal side and spontaneous subsided. As you said, could be some kind of an autoimmune phenomena which is transiently occurring, as Subhash was telling. We do not know actually what is causing it. Only time will prove. Sometimes it will come. So many cases have come. I have seen another old man who had exactly the same thing. This is even much before the antibody has been described. Then when I put him on thinking there could be seizure, I'm sure it's not a seizure, but I put in carbamazepine. 2 weeks later, everything subsided. I withdraw the carbamazepine, no further recurrence of seizure. So carbamazepine might not have done the trick, but whatever it is, they improved.
But in case of autoimmune encephalitis, without putting them on any treatment, it is unlikely that they will completely subside. They should have a kind of a progressive course. So
Yeah.
that is unlikely, but follow-up is must, at least for a year or so.
Right. So we'll go to the long case. It's the story of a 70-year-old man. He was apparently already till 1 day prior to admission when he noticed blurring of vision and diplopia, associated imbalance while walking, with a tendency to fall to the left. While standing also, he has a tendency to drift towards the left side. He was telling that the diplopia was more on looking to the right. He is hypertensive and diabetic on treatment. So blurring of vision on diplopia 1 day and tendency to fall towards left side 1 day. This is the position of the head when you position the head. Answer the video description. Made him straight. Right. So the concept a little later. Yeah. Look at the eye movement. I'm asking him to look to the left side. Right. Right, up and out. Straight, left, up and out. And left, down and out. Down. Right, down and out. Right, up and out. Straight up. Left, up and out. Left, down and out. The convergence. Okay, you want to see the video once again, or can you somebody says what could be the problem in this patient? Or I'll show one more thing. I'll show the finding. Head tilt towards the left side. You have to see what you observe is that right eye is up and left eye is down. So the question is it right inferior rectus palsy or a left inferior oblique palsy or something else? I'll show the video once again. This is the position of the eye. Or I will show the freeze film. That will be easy for you to understand. Let us the freeze frames once again. This is the head tilt to the left side when you observe it first. This is the primary position. When you make his head straight, you find the right eye is up, left eye is down. And he's complaining of diplopia more on looking towards the right side. Okay. Now this is the position. He was complaining of diplopia, but in all other directions, the vertical discontinuation. If you look at very carefully, look once again. Now you find that the right eye is up, left eye is down. If this is to occur, could be either a right inferior oblique palsy or inferior rectus palsy, or a left inferior oblique palsy, because the left eye has not gone up, so it is coming down, or the right eye is not coming down, that is why it is up. So this is the position this is the possibility you have to keep in mind when you find a disconjugation like this. Now I show the position in all directions. This is on looking to the right and down. This is the position looking right up and right to the right and up. Again, you find a vertical disconjugation. Right eye is up, left eye is down. Right. In this position, you may think that the patient has got weakness of the right inferior rectus, or he has got a left inferior. Same thing you can keep in mind. Now look to the left side also, he has got a vertical disconjugation. In this position, you may think that he has got a right superior oblique or left superior rectus weakness. Okay. So again, the vertical disconjugation is there. Here looking up again, the same thing. Right eye is up, left eye is down. Now, what do you think is the likely possibility? how can the patient have right inferior rectus and left in a superior oblique palsy on looking to right and left side? It's not possible.
So the head tilt favors a superior oblique pulse.
Okay, I'll come to that. If it's a superior palsy on this side, on the left side, come back to the question again. See, if it is a left superior oblique palsy, you expect the left eye to be up.
Sorry, sir, inferior oblique, sir. Left inferior oblique.
Left.
The head tilt.
You mean I did not hear you? Left.
Left inferior oblique pulse, sir.
Inferior oblique palsy. Yeah, it could be.
Yes, sir.
Yeah, that's a possibility. That's one possibility. Is left inferior oblique palsy or right inferior rectus paralysis. That's a good possibility which you have to keep in mind. Okay. If it is, I'll come to that point again. One more thing you should remember, what is the head position he had? He had turned the head towards the left side. Okay, now I'll explain them one by one. Now, suppose you look at the disconjugation. Is it same in all directions? In all directions, the vertical disconjugation is the same. At no place it is becoming closer to one, it become more parallel. It remains the same in all directions. So if you find a disconjugation remaining in all directions in equal fashion, you think of a skew deviation. Now I'll come to your questions one by one. Now, first one can be an inferior rectus paralysis because patient is not looking right and down. Other possibilities left inferior oblique, as he said. I'll come to the reason one by one. He has got a head tilt towards the left side. Suppose he has got a right inferior rectus paralysis. Where should have been the head tilt if at all it is present? Because inferior rectus is an extorter. So if right inferior rectus is paralyzed, I compensate by keeping the right eye extorted. So I turn the head towards the right side and not to the left side. Okay, you understood? So head deviation is always, remember the dictum, in extraocular muscle paralysis, the head tilt is always in the direction of action of the muscle. Right inferior is extorted means the head also to be in that direction. Here it is towards the left side, so it cannot be inferior rectus paralysis. Because since it is started, if inferior rectus is affected, it should have been to the right side. Now, then another question is that if that is so, and head tilt towards the left side and upward position of the right hip, with right superior, then you said, why can't be superior oblique pulse on the right side? It can explain the head towards the left side. Okay, it can also explain the upward position of the right eye. You understood? If right superior oblique is paralyzed, he could have head tilt towards the left side, agreed, and the right eye should be up. But in that case, the diplopia should have been more on looking to the down and to the left, not to the right side. So it's also not fitting with the superior oblique palsy. Then a left inferior oblique palsy, as you said, can produce diplopia and looking to the right and head tilt towards the left side. Because imagine that he has got left inferior oblique palsy, inferior oblique on the left side is an extorter. That means his head will be tilted to the same side. And diplopia will be more looking to the right and down, as you already said. But in that case, the eye on the left side should have been down and not up. Because inferior oblique palsy means the eye should be, inferior oblique is an elevator. It should be down and not up. So what test will you do to find out whether this conjugation is equally present in all directions? If it was due to non-extraocular muscle paralysis, especially an indot or extort is paralyzed, you make the indot work in tilting the head. Then you can make it obvious or make a more weakness can be made obvious. So we did a head rotation test. You can see what I did.
ഇനി രണ്ടായിട്ട് കാണുമ്പോൾ ഇപ്പൊ രണ്ടായിട്ടാണ് കാണുന്നത് അല്ലേ?
ഇപ്പോഴോ 2 now.
ഇപ്പോഴുണ്ട്. ഇപ്പോഴ്
is telling 1 now.
ഇപ്പൊ
Now 2 is telling.
ഇപ്പൊ
ഒന്ന്
ഇപ്പോഴും ഒന്ന്. ശരി. ഇനി ഇങ്ങനെ നിൽക്കുമ്പോഴേ ഇപ്പൊ രണ്ടായിട്ടാണല്ലോ കാണുന്നത്. ഇനി ഇപ്പോഴെങ്ങനെ?
Left side.
1 2
Saying two again.
ഇങ്ങോട്ട് നോക്കി ഇപ്പോഴോ
Okay. So
ഇപ്പോഴും 2 തന്നെ. ഇപ്പോഴാണ് കൂടുതൽ 2ആയിട്ട് കാണുന്നത്. ഇപ്പോഴാണ് കൂടുതൽ 2ആയിട്ട് കാണുന്നത്. ഇപ്പൊ അത്രയും.
he is seeing double when whichever direction the head is tilted. That means it is not corrected on turning to one side and not aggravated on turning to one side. That tells you that the disconjugation remains same irrespective of the rotation of the head. If it had been a superior oblique or inferior oblique palsy, then should have been more on tilting to one side, less on tilting to the other side, which is not present in this patient. So that tells you that this vertical disconjugation is present in constant all throughout the position of the case, and that is characteristic of skew deviation. So I think any doubts in this thing, if you have got a doubt, please ask me, I'll clarify that. Anyone, please? I'm sure you must have some doubt in that. I can clarify that. I'll say show the free film again. If you have no doubt, I can proceed.
What is the cause, sir?
And of course, I come later on. See, the video has been brought, no? I mean, I have shown the video not for the etiology and all. I'll come to the etiology later on. Now, you must know how to localize. Why it cannot be, why can't be an extraocular muscle paralysis? Why do you want to say it's a skew deviation? That's the explanation I'm trying to offer. If you understood, it's okay. That means the vertical disconjugation is constant in all directions of the case. That's the point. So, for example, in also more logic, if you want to diagnose each muscle, if you keep in mind, it cannot go with that thing. For example, if you think of a right inferior rectus paralysis, that is this kind of adaptive or inferior oblique palsy, the head tilt is not favoring that. That is the point here. You can favor inferior oblique palsy, but not inferior rectus paralysis. The head tilt outwards left side can occur with the left inferior oblique palsy. In that case, this eye should have been, then inferior oblique is an elevated. So that can go with inferior oblique palsy, but in that case, diplopia should be a bit more on looking to the right end. So many points, there are points against each individual muscle paralysis. Okay. Now, rest of the video, when it's made to stand up, he has tendency to fall towards the left side. His whole trunk goes towards the left side.
കൈ വിട്ടോ ഒരു മിനിറ്റ് വേണേ പിടിച്ചാൽ മതി. നടന്ന് നോട്ടിരിക്കുക മുമ്പോട്ട് വെച്ചേ മുമ്പോട്ട് വാ മുമ്പോട്ട് വയ്ക്കേ.
Okay. Now, where is the site of lesion in this patient? He's got a skew deviation with the right eye up or left eye down, and he has got a lateral pulsion to the left side. Yes. Yeah. Anyone?
Midbrain, sir?
No. He's got a lateral pulsion to the left side, and the right eye is up, left eye is down. It could be lesion anywhere from the left otolith, left lateral medulla, or right MLF or right midbrain. It is a lesion is in the left graviceptive pathway. I think I'll explain it a little more. I'll show the pathway, then you'll be able to understand it a little bit. It's a lateral pulsion to the left side. His head and tongue deviate to the left side. That means his sight is either the left medulla or right pons or midbrain. And this is what the MRI showed. He had got a right midbrain infarct, including a middle thalamus. Let us see how this pulsion, how the rotation of the head, how this skew deviation is occurring.
Sir, one doubt.
Yeah.
In your video, there's a right eye adduction was impaired. So whether we will be able to localize based on that finding.
Yeah, probably he may, as you said, it may be an associated middle rectus involvement, could have been possible. But I was not very much convinced about right adduction failure. Anyway, Okay, and diplopia is also more only to the right side and not looking to the left side. Yeah. So if it is there, it could favor another point favoring right midbrain. My idea was to bring to show that it is not extraocular muscle paralysis, vertical disconjugation, but a skew deviation. That's the point I wanted to tell. Because it cannot fit in with any extraocular muscle paralysis. Diplopia on looking right side and this kind of a head position and the vertical deviation.
I mean, so localization to midbrain can be like with adduction involvement. Like
yeah, that can be a clue. Yeah, it can be a clue. Really. Now, the vertical misalignment of the what is skew deviation of the eyes resulting in supranuclear lesions due to imbalance in the tonic level of activity underlying the otolith ocular reflexes. That I will explain in a little more detail now. Now let's see this is called cerebellum and the control of the binocular oculomotor control. Cerebellum is involved in adjusting the relative positions of eyes during fixation and yawking of the muscles during movement. The dysfunction of this control causes skew deviation. That's a vertical misalignment of the eyes that cannot be attributed to a simple extraocular muscle weakness. So putting it other words, a supranuclear paralysis of supranuclear paralysis of the extraocular muscle is actually one of the thing is skew deviation. Now, before that, you must know what is ocular counter roll. Normally, when the head is tilted to one side, say for example to the left side, the eyes counter roll in the opposite direction. That means the left eye will indort, the upper pole will move, both the poles will move to the contralateral side. Suppose he head to the left side, the left eye will indort, the right eye will extort. Okay, that is ocular counter roll. The other way, turn to the right side, the other way occurs. Furthermore, a small skew, a vertical deviation also occurs for the hypertropic, the eye which moves in the eye which indorts moves little bit up. So the hypertropic eye or the eye which is up is indorting, or indorting eye is up. Now let us see ocular counterrolling due to activate how it is produced. Now let us see the pathway for that. Imagine that right uticle is stimulated. That pathway is connected with the vestibular nucleus and cross to the opposite side and ascend in the embryum and getting connected with all extraocular nuclei on the left side. That is superior rectus, inferior oblique, superior oblique, all on the contralateral side. When it is stimulated, and you know the superior rectus and superior oblique supply the contralateral muscles. The inferior rectus, inferior oblique supply the ipsilateral muscles. This you all know. So when the right uticle is stimulated, when you tilt head to the right side, the right uticle is stimulated. I'm talking about the physiology of the ocular counter roll. So when it is stimulated, what will happen? All these muscles on the left side will be stimulated. So imagine that on the right eye, what happened? The right superior rectus and right superior oblique will activate. They are supplied in the right side. Both these muscles are indorters. So the eye will indort. And one is an elevator, one is a depressor. Because superior rectus is an elevator, superior oblique is a depressor. But the primary action of superior rectus is elevation. Superior oblique is a weak depressor. The superior rectus action dominates. The right eye goes up and indorts. Okay. When you stimulate the right uticle, the same side eye, the superior rectus, superior oblique activated, and you produce the eye goes into indorsion and elevation. Let us see what is happening on the opposite side. Opposite muscles are the inferior rectus and inferior oblique, which will not cross. We supply on the same side. So what will happen? Both inferior rectus and inferior oblique are extorters. So they extort. And it goes down because one is a depressor, one is an elevator. Inferior rectus is a depressor, inferior oblique is an elevator. But inferior rectus is always the primary action of inferior rectus is depression. For inferior oblique, it is only a secondary, elevation is a secondary action. So the dominant movement will be downward. So the eye on the opposite side of stimulation goes down and extort. So that is what is normally happening in ocular counter rolling when you tilt the head to the right side. Now, in ocular tilt reaction, what happens is the skew deviation associated with head tilt in the direction lower eye. This configuration is called as an ocular tilt reaction. Now, the ocular tilt reaction, I'll tell the pathogenesis later on. For three components: head tilt, ocular torsion, and vertical deviation. The latter two component pathophysiology already told. Why head tilt occurs, I'll tell you. Now, the OTR, the ocular tilt reaction, indicates a dysfunction of the pathway which I already mentioned. Anywhere from the ipsilateral peripheral labyrinth to the interstitial nucleus of Cahar and the rostral midbrain. The same pathway I have shown, it is stimulated here. The right eye has gone up and intorted, left eye has gone down and extorted. So this is the position of the head. This is the position of eye. Don't forget about the head. Position of eye. Eye goes up and intorts, left eye goes down and extort. And the head tilt is a compensatory head tilt. Because the eyes are rotated like rotate clockwise, that also moves in the same direction to compensate for the diplopia. So this is what is the position the head takes. So if you stimulate the utricle on the right side, the right eye goes up and intort, left eye goes down and head will move in the direction of the lower eye. Direction of the lower eye, head will be tilted. Let us see in this particular patient what is going to happen later on. Let us see. Suppose there is a lesion here on the right utricle. What is going to happen? Just opposite will occur. It is as if the left side is stimulated. So the head is just opposite to what we expect with the right side stimulation will occur. Okay. The right eye will go down, the same lesion side will go down and extort. The contact eye or left eye will go and extort. This is utricular lesion and the medullary lesion is connected with the medulla here. So it will be the same. So you find the eye will be down, extorted, and the head will be tilted in the same direction. So in our patient, you remember the patient had head tilt towards the left side, and the left eye was up, right eye was down. Sorry, right eye was up. I forgot about it. That is called right eye was up, left eye was down. So it could mean that patient can be either a left medullary lesion, where the patient has got a left eye down and head tilt towards the left side. The same thing can also occur due to lesion anywhere in the pathway. Suppose the lesion here will produce the same appearance, here also is going to produce same appearance, and the opposite side also is going to produce the same appearance. But here is after crossing, this before crossing, all will produce the same phenomena because the pathway is same. So in the case of lesions on the medulla, the head tilt towards the left side, in the midbrain on pons after crossing, it's the opposite side. So here the head tilt, our patient head tilt towards the left side means it should be right midbrain or left middle. Okay. And the skew deviation, the up eye is the same side as the upper part of the brainstem. The lesion is in the midbrain or the pons after crossing, that eye will be up. So you can see here, the lesion is here in the pathway MLF, that side eye will be up. On the lesion is in the medulla before crossing, that eye will be down. So the mnemonic is low, low, high, high. Lower lesion produce lower eye, higher lesion produce or upper lesion produce an eye, upper eye. So that's so our patient, what had happened? He had got a head tilt towards the left side, left eye is low, right eye was up. The lesion can be either right midbrain or right pons or left middle. Now this is the same thing showing in position. In skew, higher eye is contralateral to the medullary visual lesion, ipsilateral midbrain lesion. The mnemonic is low, low, high, high. And what they combine the patient skew deviation, vertical diplopia, sometimes torsional diplopia. There may also be counter rotation for both eyes also is an illusion of tilt of the visual. So these people also can combine illusion of the visual world. They may think that your door is tilted to one direction, or so-called floor on ceiling phenomenon. You feel that the floor on the ceiling, the fan is all coming from below. That kind of a tilt, or remember, tilt phenomena can occur with skew deviation. In a mild skew deviation, this is a very gross skew deviation, what I've shown you. Sometimes skew deviation is so subtle that you may not be able to detect by just observing the patient. In that case, you can do an alternate cover, just move one cover from to the other eye. You find movement of the eyeball occurring from below upward, telling that he has got already a mild, this thing is a deviation has been existing before the cover was put. The skew deviation can be of two types, competent or incompetent. Our patient had a competent deviation. The vertical separation is constant in all directions in the case. Then only it is easy to make a diagnosis of skew deviation. If it is inconstant, then it will be difficult to differentiate from obstructive muscle paralysis. In incompetent, the vertical separation is different positions of the case. Uncrossed hypertropia is relatively compact, that is, right hypertropia in the right case and left hypertropia in the left case. So when you look to the right side, right eye is up. When you look to the left side, left eye is up. On the other hand, in the competent type, it will be the same in all directions. Right eye will be up wherever you look, right side or left side, right eye always will be up. But here, it changes, it alternates. So this is incompetent skew deviation. Okay, so that much about that case. Any questions in that case before I go to the next one?
So one way of differentiating skew deviation from nuclear or infranuclear palsy would be to make the patient lie down and take away the effect of gravity.
Yeah, that is, yeah,
improves it.
Yeah, perfectly right. So there are two ways you can differentiate the two. One you can say one is for the disconjugation varies with the position of the case. Second thing is that the duction movement, the eye movements were normal in the case of skew deviation, will be abnormal in the case of paralysis. Then the gravitational effect, because skew deviation is gravity dependent. So when the patient lie down, the skew may usually disappears, but that will not disappear if there is infranuclear paralysis. Usual problem comes is that you see, say, suppose right eye is up, I got a skew deviation, right eye up. It could be either a skew deviation or a right superior oblique palsy. Okay, that's a usual confusion occurs. The other thing but to differentiate is that you look at the fundus of the patient to find out whether that eye is intorted or extorted. Because intorsion and extorsion, you cannot just observe the eye and find out whether it remains intorted. We are not seeing the movement. Remains intorted or remains extorted. So you look at the disc and find out draw a line between the macula and the disc. Normally it is almost in a horizontal line. If it is the macula is up, means that eye is intorted, down with that eye. I'm talking about the right eye of the patient. Right will be extorted. So in the case of skew deviation, the eye which is up is intorted. Whereas in the case of superior oblique palsy, the eye which is up is extorted. Because superior oblique is an intorted, so eye goes into extortion. So that can differentiate, that's a better way of differentiating a superior oblique palsy from a skew deviation. There are three ways by which you can differentiate, like infranuclear from this thing.
Is there a difference in the etiology between this competent and incompetent?
Yeah, the incompetent this thing one is alternating, is usually seen in tactile lesions, region the midbrain and tactile lesions. The other classical skew is seen in lesions the lower medulla and bones.
Yeah, no, that is localization, but I mean etiology wise there is no difference.
The etiology wise no difference. Mohan sir, mute ചെയ്യണേ.
Sorry.
Okay, shall I go to the next case?
I think this skew deviation has been very much emphasized in hints, where you have to differentiate between a vertigo and a stroke or TIA.
Correct.
But I think it must be very subtle, and as you rightly said, we have to really look for it, or maybe by cover test, because a lot of times we don't find it there, even though we look for it. So maybe it is subtle, and we have to positively look for it.
That's the time ideal to for the cover and cover test. You can make it. Yeah. So shall I go to the next case now?
Yes, sir.
Yeah. This is a story of a 19-year-old boy. He presented the history of numbness of both hands 2 months back, which after 1 week extended to both upper limbs. And over the next few days spread to all over the body below the neck. That is what he's telling. For 2 to 3 months now, first started as both hands. After 1 week extended to both upper limbs. And over next few days, all over the body below the neck. He also noticed imbalance while walking, especially while closing the eyes. At night as well, so walking imbalance. So this is the video of the patient. Ocular movements are normal. Tailor's examination are all normal. Motor system, tone, neck muscles normal. Tone power are all normal. Very good, very good. He had mild incoordination the left upper lip, right? He said there was not consistent incoordination there. He had no pseudoarthritis. Keep it like that. Subtle pseudoarthritis on the left side. It's got had this gland stable. Maybe there on the left side. The only power was normal. No reflexes, all reflexes were absent. Even abdominal reflexes also. He's only 18 years old. So Vendor was down the. He is able to feel vibration in both upper and lower limbs. I checked the proximal part also, they're also in. Joint position is normally the upper limb. അതേ മാതിരി ഈ കൈ പറയണം ഇപ്പോഴേ thrombus was positive. ഇങ്ങനെ ഒരു കാലിനെ വശത്ത് കാര്യം വെച്ചിട്ടുണ്ട്. Yes, got tandem walking, but I think I forgot to show the. Yes, if joints are impaired on the right foot, that I don't know with that PDF, but I missed it. I think somewhere other it came. Joint position was impaired in the right foot. Otherwise, all vibration, everything was normal. Thrombus positive. Tandem walking was negative. So power normal. DTR all absent. Sensation impaired joints and so the toes. Vibration normal in upper and lower limbs. Thrombus positive. Gait ataxia is present.
So pain and temperature.
Normal. So where is your localization? What is your diagnosis? Any clarification you can ask?
Could be a peripheral nerve involvement, sir, but some odd points are there. History-wise, predominantly upper limb involvement followed by lower limb involvement is odd for peripheral nerve. Otherwise, it fits into peripheral nerve. Other odd point but is the left upper limb ataxia, that is finger nose incoordination. This also is unfavorable for peripheral nerve.
Yeah, that can occur with the sensory differentiation also. Any sensory ataxia can be occurring the upper limb can have incoordination.
So otherwise, it favors a predominantly large fiber neuropathy, sir.
Okay, large fiber neuropathy. But
ganglionopathy is a possibility, sir.
Pardon?
Ganglionopathy.
Yeah, ganglion. That's a bit. See, grossly asymmetrical, starting in the upper limb. That you remember that peripheral sensation may be normal in ganglionopathy. Sometimes joints and septum may be affected proximally in the muscles. That may be responsible for the ataxia. Sometimes in ganglionopathy, they come with severe ataxia. And you may, if you do the joint position sense and vibration only in the distal part as we normally do, it may appear normal. Unless you do the vibration loss of the proximal part. That may be the only area may be appearing, because it is not pick up just like a dying back phenomenon. It pick up random. They may be asymmetrical. So that point you have to keep in mind. So for example, even the proximal proprioceptive input is lost, proximal muscle, they'll be more ataxic. But you want joint sense will be normal. So again, that point you have to keep in mind, because usually what we do, we check the vibration distally and then walk off or normal. But fail to do in the proximal part, especially in the torso and the shoulder you have to do. But here the vibration was normal, even proximally. But joint sense, unless because being a large joint, very difficult to test on the hip and all. Indirect evidence is the ataxia by closing the eyes. That's maybe the only evidence. The clue for the is a peripheral nervous system involvement is the loss of reflex. You can argue that it's a constitutionally absent because everything is absent. But losing abdominal reflex also is absent, is also uncommon for a constitutionally hyperreflexive individual. But that possibility you can totally rule out. You can still postulate a lesion in the cerebellum, telling the reflex may be absent constitutionally in some individual, because all are absent in this patient. But he has got a sensory symptoms in the upper and lower limb, and with absent reflexes, the lesion is likely to be in the periphery. Okay. But one cannot rule out totally a posterior column involvement, where the reflexes, in that case, you have to think that the reflex is constitutionally absent. So I'm only thinking broadly, but the first possibility should be ganglion neuronopathy. Your possibility sensory peripheral neuropathy is possible, but the asymmetrical involvement is odd point. And starting in the upper limb. Now, what investigation you want?
Nerve conduction.
Okay. This is a motor conduction, all normal. FA is normal. Sensory potential is normal. Now what is your diagnosis? Where is the localization? You want to change it to somewhere else?
Proximal to the dorsal root ganglion.
Yeah, what do you call that?
Radiculopathy.
CASP, chronic inflammatory sensory polyradiculopathy. That's a possibility. Can you rule out a posterior column lesion? What is against a posterior column lesion? absent reflexes. The point against posterior, see, sensory potential normal mean naturally you have to think lesion proximal to the ganglion. The ganglion neuronopathy is unlikely in this patient. So, or made the posterior root or the posterior column. Okay, in fact, what is posterior column? Nothing but the central process from the dorsal root ganglion. There is extension of the dorsal root is posterior column. The differentiating point between the two is that in posterior column, reflex will be preserved, whereas posterior root, reflex will be absent. But as already told, whether we don't know his reflex status earlier. So you want an MRI to learn to posterior column lesion. MRI was normal. No posterior column lesion seen. So what is your impression now? It is CASP. But how to prove your point? What other test you'd like to do?
So SSCP can be helpful, sir.
Yeah, very good. You can't do it SSCP, correct? When SSC could be done, but that was not done because my technician was not very expert in that doing it.
CSF, sir.
Yeah, you can do the CSF and the contrast MRI because because the roots are inflamed, mean they can usually get enhanced and thickened. So you can do a contrast MRI of the roots in cervical as well as the lumbar. So you see the nerves which is done. It's got now the brachial plexus nerves are all thickened. And you can make out the thickening of the nerves here. These nerves you can, I don't know, you can make it out. This is coming out, the nerve root. This is the intervertebral foramina. The nerve root is coming out. They're all get thickened there and enhancing. Again, you can make out. So this is the dorsal root ganglion. The ganglion part. This is the one which is ganglion. That also is enhancing with contrast. This inside the spinal canal, see the quadricular roots that are also getting enhanced. So diagnosis CASP. So the CASP, the clinical picture exactly mimics ganglion neuronopathy. The only thing is the conduction, it will be known. Otherwise, it cannot differentiate between one and the other. So any questions in this case?
So if you such a inflamed roots, the sensation is normal, sir.
Yeah, that's what you find in the MRI and what is the dysfunction caused by that can differ from individual to individual. Sometimes you may not find anything in the MRI, severe damage will be there. Sometimes lesion may be so thickened, but findings may be very subtle. Even though this much of reflex loss is there, his ataxia is very minimal. Look at his ataxia, very minimal ataxia. It's ordinary early neuronopathy, or even they are totally unable to walk because of severe sensory ataxia. So that can be from individual to individual.
So Madhu, was this CSF done? CSF?
Now CSF, in fact, I forgot. In fact, I know you will be asking that thing. In fact, this the case was my for the previous case. I searched, looked for the CSF. CSF is not there.
No, what I'm saying is that how was she treated? I mean, it was probably was it an inflammatory disease because of?
Yeah, he treated with IBMB, totally improved. He became absolutely normal.
So is the behavior, clinical behavior, not the findings, but the clinical response to treatment and all of CISP same as CIDP, and would they respond the same way?
Yeah, respond the same way.
Okay.
If it is not due to some paraneoplastic syndrome or HIV, they respond very well.
So here also starting in upper limb is an odd point?
No, not at all, not point. That is a typical point, typical feature of ganglion neuronopathy or CASP. They do not follow our dying back phenomena, distal symmetrically in glove sucking pattern at all. They can affect anywhere. It can start from the body, it can start from the proximal part. Anywhere they can start. That's a clue. We have to suspect that this is a ganglion neuronopathy or a CASP.
Thank you, sir. Very good.
Okay. Yeah. Shall I go to the next?
Sir,
Yeah,
so the
please.
MRI contraction enhancement is in only the ventral and dorsal roots, or only in the dorsal roots, sir?
No, that I think it is seen in both sides. I am not very sure because it is in the foramina. That is difficult to say from the MRI picture whether it's anterior root or posterior root. That is difficult to say.
And then we expect some FA prolongation, but is not seen in this case.
Expect some what? FA
prolongation of FS.
Yeah, correct. If that's occurs only if the motor part is affected, but he has no motor weakness at all in this patient.
But in the CISP as such, this is more or less an extension of the, not extension, it comes in the same category as the ganglionopathies.
Exactly.
And they are very specific antigens. So in them, the term itself is focusing on sensory. Motor is not expected to be involved.
Correct. Exactly. Exactly correct. Okay. Now, this is another story. This patient had a bike accident, following which he noticed diplopia 2 days prior to admission. Okay. It's also a tricky case you have to concentrate because an exercise on localization. Look at the position of the, I'll show the video. This is the primary position. Ask me to look to the right side.
Look carefully. Everyone
Left side. Down. Up. Okay. I'll show the video once again. We can go step by step. Okay. It's good. Look into the right side.
Look carefully. Everyone
look into the right side. Left side. Down. Okay, what do you observe in this patient now?
Restriction of adduction of both the eyes.
Right. And you could find some nystagmus also.
Nystagmus.
Yeah, nystagmus part again. Now, on looking to the right side, yes, but some nystagmus, you will not be able to evident from there.
Look carefully. Everyone
some nystagmus in there. Looking left side also, there is some nystagmus. Okay. Abducting issue is some nystagmus, but action is there. Okay. Right. Now, my question now is that, is this due to INO or due to medial rectus weakness?
What are the convergence? Sir?
Yeah, correct. Convergence. Okay. So let us see the left eye is also what left eye. So left eye actually it will go to the exotropic position. It will abduct it. I'll show that next picture. Next film. I'll show. Okay, wait. So severe abduction of the abduction failure left more than the right, and abduction is also incomplete bilaterally, which I will show in the next video. Elevation is restricted bilaterally left more than the right, and downward movements are normal, but for mild restriction on the left side. I think I showed this video also. Let us see the findings. Same patient video one. Now we concentrate a little more.
Okay, see what is happening. I'll analyze later on.
Yes, good. Right abduction is not normal.
Adducting. Right eye. Abduction is full, not complete. Not complete. Very good.
Now look into the left side also.
Not complete.
Right abduction is not full.
The left side.
Left side also. Left
right
abduction
eye,
is
no
not
adduction.
Full.
No adduction. Left eye again incomplete.
Okay. So it's not only adduction failure. Abduction is also not full. Elevation is left. Right eye is moving up little bit. Left eye is not moving as much as the right side. See the disconjugation on the up, looking up. Left eye is little down compared to the right side.
Up than the left eye. See, left eye is not fully moving up. Right eye is moving little more.
Looking down also, see, right eye is moving much more down than the left eye.
Left eye is less. Okay, left less. Okay, but it is still moving down.
Okay, so it's not a simple adduction failure. So I'll show the one video once again. See, look once again.
Okay, see
As
what
to the
is happening.
patient, look to the right side. The right
So left
eye
eye
is
is
not
not
abducting fully.
adducting. Right eye
The sclera is still visible. Left eye is not at all adducting.
not complete. Not complete. Very good. Okay, not complete. What do you right?
I must be
Left side.
Look to the left side,
Right eye, no
maximally
adduction.
left side.
No
The sclera
adduction.
is visible on the
Left eye
left eye
again
also.
incomplete. Okay.
Then the abduction is not
Above.
complete. Looking up, the left eye is not
Deviation
moving
is
as much on the right eye.
And bilaterally, മുന്നോട്ട്
So you
നോക്കിക്കേ.
can see that left eye is little
But
down
right
compared
eye
to
is
the
moving
right.
little up than the left eye. See, left eye is not fully moving up. Right eye is moving little more.
Now looking down,
താഴെ നോക്കുവാനെ, that is okay.
right eye is moving much more down than the
Again,
left.
left eye is
That
less.
means left eye elevation and depression is less compared to the right side. Okay.
Okay, see what is happening.
So what is the site of lesion now? So these are the findings. Once again, left eye is little out. Both eyes show severe adduction failure, left more than the right. Abduction is incomplete bilaterally. Elevation is restricted bilaterally, but left more restricted than the right. Downward movement is normal, but mild restriction on the left side. So what are the possibilities? Possibilities, can you see the bilateral MLF with the left third nerve palsy and bilateral sixth nerve palsy? Or is it bilateral third nerve with bilateral sixth nerve palsy? Or is bilateral MLF, left third nerve and lateral rectus paralysis? Bilateral lateral rectus paralysis. Or something else.
So convergence.
I'll come to that. So when I'll show the convergence. Okay, the first question is sort out one by one. The adduction failure. Is it bilateral third nerve or bilateral MLF? That's the first question. Okay. If it is adducting, then you can be definite that it is not third nerve question at all. Just with something else. So whether bilateral third nerve is or not, we can find out by looking at the convergence. So what does we do to converge? Let's see the convergence now.
പേനത്തിന് നോക്ക്, പേന നോക്കുവാനെ, പേന നോക്കിക്കേ.
No
പേന നോക്ക്.
convergence.
പേന കാണാവോ സനു? പേനയുടെ തുമ്പത്ത് നോക്കിക്കേ. നോക്കിക്കോണേ, നോക്കിക്കോ, പേന തന്നെ നോക്ക്. നോക്കുമോനെ, നോക്കിക്കേ, പേന തന്നെ നോക്കിക്കേ. ഓക്കെ.
So
ഇനി പേന കാണാവോ സനു? പേന കാണാവോ? പേന നോക്കിക്കേ. പേന തന്നെ നോക്കിക്കോ. പേനുണ്ട്, പേന നോക്കിക്കേ. നോക്ക്, പേന നോക്ക്. ഇങ്ങോട്ട് നോക്കിക്കേ.
okay, convergence is absent. That means what?
Bilateral third nerve is there.
Yeah, it could be bilateral third nerve, but why can't be superior INO? When their superior INO is bilateral INO with convergence palsy, superior INO, the lesion in the midbrain. So an absence of convergence does not totally rule out, make you think that it is male rectus paralysis, but also could be due to superior INO. Now before that, you see the last part of convergence is I was closing the patient's one eye. Can you tell you reason why I did so? For convergence, there is no reason why should one close one eye. This is because if you are in the habit of doing convergence in many people, then you will know that many normal individuals, they won't be able to converge at all. Because most of us, or not most of us, some of us have got concomitant squint. And we have got one good eye and one lazy eye. So we tend to use that good eye all the time. So when you ask the patient to convergence, I try to look at with the good eye, try to neglect the left eye. So you may feel that convergence is defective because one eye is not converging at all. To avoid that, what will you do if the patient is not converging? You try to close one eye, the eye slightly adducting. So the other fellow will come and adduct. That tell you that it is actually it's a concomitant skin that is preventing convergence and not a true convergence failure. You understood what I said? So when the patient may try to look at the object only with a good eye, neglecting the other eye, neglecting the lazy eye, supposedly resembling a lack of convergence. To avoid that, the patient convergence is incomplete. Make the patient close one eye and then the other eye is made to focus onto the converge onto that object. So you can find out this thing. So that is why I try to close. So so here now convergence is absent. That means the lack of adduction can be either bilateral INO, that superior INO, or bilateral third nerve palsy, as you said. Now let's see the bilateral abduction failure in this patient. Next problem is orthotis. We have sorted out the adduction, which we said ultimately we can differentiate the two. Then abduction failure. What could be the possibility? Is it bilateral rectus paralysis or bilateral gaze palsy?
In view of the nystagmus, it may be a bilateral gaze palsy.
No, that because even nystagmus can occur with extraocular muscle palsy, called ocular nystagmus. No, the nystagmus is not a very gross nystagmus, only fine nystagmus, which is not a typical of MLF which is seen here. But I agree with that. That is one point by which you can say. But in extraocular muscle paralysis also, the one which eye moves can produce nystagmus. That's called the ocular nystagmus. You know the reason why the nystagmus occurs? Suppose you look into the left side. My lateral rectus is not working. Okay, left eye is working normally. So in order to make my medial rectus contract, I give extra innervation by medial rectus. That extra innervation goes to the opposite eye also. So that will overshoot. So according to the Herring's law of equal innervation, the same impulse should go to the contact line. So instead of 10 impulses to the right eye, I gave 15 impulses. So the left eye gets, instead of the 10 impulse, 15 impulse it will get. That is more than what is required for him. The left eye rectus will overshoot. But it is said what is a nystagmus. So you can extraocular consequent what is this called ocular nystagmus. So just finding some few beats on nystagmus on the other side did not make you suspect it's but there's a point, again with that. But what is now next question is how to prove that point? What PET test will you do to differentiate is a bilateral abduction failure issue to the lateral rectus or gaze palsy?
Checking all the movements, in all the corners of the.
No, gaze palsy, voluntary movement is restricted. Whether it's gaze palsy or a weakness, movement will be restricted.
By checking the single eye at a time.
Yes, sir. Individually.
No, individual eyes you can't test. Because see, if you close one eye and check, do you think the gaze palsy will be corrected? No, never. You close one eye and try to move a direction. It also move. The gaze palsy means for the ocular movement, whether it does not matter whether you close one eye or not. It does
Is
not
it the cover uncover test, sir?
Not uncover. What you do, ocular cephalic. Okay, ocular cephalic reflex you do. If you are able to make the eye move by ocular cephalic, just like told before, the upward gaze palsy. To call a gaze palsy means upper motor neuron palsy. You have to show that the element is intact. Then you have to make the muscle move by some reflex means. Otherwise, you can't differentiate. Okay, suppose you've got a weakness of the wrist jaw. How can you know it is not a human element? You have to find either reflexly that restart to contact, or should be brisk, some other picture should be there. Otherwise, you can't differentiate. So similarly, if by ocular cephalic the eyes are abducting fully, That cannot occur with either lateral rectus palsy. It can occur only with the UMI and gaze palsy. That too, if the gaze palsy is due to the abducent nucleus, oculocephalic will be absent still. But the lesion is the PPRF or lesion the frontomesencephalic reticular pathway, then the oculocephalic will be intact. Okay. So let us see, just like the previous one, let us see, do this test, oculocephalic. Now look at the oculocephalic. Full abduction. See, the eyes is got full abduction.
See the abduction. See the abduction. Full. It's coming up to the periphery. Did you see
It is
this?
going up to the periphery. Did you see that?
Okay.
Yeah, voluntarily, it was not coming out periphery, but oculocephalic going to the periphery. So what does it tell you now? Can you say?
Human types.
Yeah, it is not a lateral rectus paralysis, not an abduced nuclear complex lesion. It can be lesion in the PPRF or above. The frontomesencephalic pathway and above. So the lesion can be, where it could be the lesion now? It could be in the midbrain, affecting the frontomesencephalic bilaterally, affecting the third nerve, bilateral third nerve, or MLF lesion. Now, see, what you observed was that it's also got restriction of upward movement bilaterally more on the left side and restriction of the downward movement on the left side. So that you can't explain by an INO alone. That means it's got a third nerve on the left side. That is why it's an exotropy also on the left side. You understood? Because if it was due to a gaze palsy, lateral gaze, INO alone, why should the vertical movement be restricted? It should not be restricted. Okay. You can say it's got upward gaze palsy. Yes, it could be upward gaze palsy, but it is asymmetric. Left eye is not moving up as on the right side. If it's a gaze palsy, that should not occur. That means it's got an element lesion of the extraocular muscle on the left side for movement up and down. And so middle rectus up and down, and it means that he has got a left third nerve. So synthesizing everything together, he has got bilateral INO, he has got left third nerve, and he has got a bilateral lateral gaze due to a lesion in the midbrain producing effect of the bilateral frontomesencephalic pathway. This I already showed. So left nuclear third nerve can be, left nuclear third nerve also is possibility because right superior rectus also is weak. Right INO, bilateral gaze palsy with intact VOR. Midbrain lesion more on the left side. Any questions in that case? A little tough case, but it's a good exercise to find out how you can sort out one, the site of lesion, confirm the other by doing the bedside test. Any questions? Why do we think left third nerve nuclear lesion? Because the right eye is not also not moving up as on the left side. Yes. Any questions?
Sir, good morning. Sir,
yeah.
Yes, sir. Yeah.
Now I can recognize my voice.
Yeah. Yes, sir. Sir, in midbrain lesion, the accumulation failure is there. So, can we just think that the accumulation failure is? I mean, we know that there is a INO, there is a left third nerve as well as frontomesencephalic pathway lesion on both sides. So, by the accumulation, can we say that it's more likely in the midbrain compared to the pons and all?
Yeah, of course. It is. What is it is correct. The patient's got a convergence palsy means his lesion has to be in the midbrain. You are exactly right. Yeah. The point was how to. I want to prove it. See, okay, we know that the adduction failure is due to the bilateral third nerve or INO with convergence pulse, superior INO. That's a possibility. But the abduction failure, is it in the midbrain or not? How do you know? So it can be pontine plus midbrain or only midbrain. Now we know everything can be explained by lesion confined to the midbrain alone. We need not bring down the lesion to the pons. That's the point I was trying to say. That is why we want to check for the ocular capillary, so that the eye is going fully in the abducted position.
Okay.
Okay.
There is a doubt.
Yeah, please. Yes. Yeah.
If there is a left third no palsy, ocular, when you elicit oculocephalic reflex, the movement should be diminished on the left.
Yeah, that means the adduction will be diminished, abduction will be normal. If suppose he has got a left third now, if you do the ocular cephalic, the eye will not adduct. But abduction,
upward and downward also will be.
It will be restricted. Correct. It will be restricted. Absolutely. So element means every movement will be restricted by whatever means. So the ocular cephalic gunam is a usefulness ocular cephalic is to find out whether the abduction part is due to the lesion in the pons or lesion in the midbrain. Can it explain it? That's because everything else favors a midbrain lesion.
How was the pupil, sir?
Pupil was normal, because that's usually what we find in midbrain lesion, nuclear third, people are usually spared. That is called a Mohan's rule, whatever it is. Here it is spared. An MRI showed a lesion in the midbrain in this patient. Not a gross, severe lesion, restricted lesion in the in the midline central region, affecting bilaterally.
And concussion in nature.
Pardon?
Concussion.
Concussion. He had a trauma, but some bleed was there in that midbrain location. Okay, shall we stop here? Only 10:25. Okay, so I got another thing at 10:30. If you want, you can join the talk by Dr. Jalesh. It's a master class on Jalesh. IN meeting. Yeah, please.
So the link is there, sir, for that master class?
Oh no, every IN meeting will have that link. They will send you with the IN digital team will be sending the link to your email.
Okay.
So what is the topic? MS.
No. Topic is on Jalesh Panikkaran in neurourology. Say last 2 Sundays I took on class on bladder, anatomy, physiology, and disorders of bladder. I took. This is the 3rd lecture on by Jalesh. He's talking about physiology of sexual functions. That is he's taking. I gave the topic to him. It's at 10:30.
Okay, sir.
Okay. So
thank you.
Yeah, thank you. We'll meet this Sunday.
So next week is it at 10 o'clock? Next week?
Next week is at 10. At what time you want? I can do it 9 o'clock or 10 o'clock. No problem.
10 will be ideal, sir.
Okay, we'll do it 10 o'clock. No problem. 10 o'clock. Yeah. Very good. So next week 10 o'clock.
Okay, sir. Thank you, sir.
Thank you.
Thank you. Very tough case.
Okay, thank you.